Good morning. The Karl Storz Lecture in Innovative Surgery was named for SAGES' first pioneer in endoscopy. It is fitting that the 2008 Storz Lecture should be presented by a man whose career defines innovation. Thomas Krummel is currently Professor and Chair, Department of Surgery, Stanford University School of Medicine, and Surgeon-in-Chief of Lucile Packard Children's Hospital and Director, Surgical Innovation Program, Stanford University. Over his distinguished career, he has become an expert in innovative techniques for teaching surgery and has done groundbreaking work in surgical simulation. It is fair to say that he has changed how we teach and how we learn surgery. Tom has published more than 24 papers just on simulation, computer science, and medicine and surgery. He is a member of more than 30 medical associations, editor of 3 journals, and reviewer for 8 more. He has served as director of the American Board of Surgery and the joint SAGES ACS FLS committee, among many other undertakings. Today, he will evaluate where we are going in surgical education and hopefully suggest to us how we can get there. It is my pleasure to present Thomas Krummel, innovator and educator, to present the 2008 Karl Storz Lecture.
Well, I'd like to thank Dr. Park for that honestly very generous introduction. He was very gracious to not mention the many missteps, mistakes, and flat-out screw-ups that are just as much a part as any small success. I'm grateful to SAGES for the privilege of speaking with you this morning, and to Karl Storz for sponsoring the lectureship, and for Karl Storz and his incredible example of innovation and creativity. Karl Storz pictured here, his workshop, his designs, and his genius with glass, steel, and now with information that is so enabling to all that we do. I think the example of putting together the clinical need, smart creative engineers, and astute business people is the paradigm for inventing our future. And what I want to do this morning is talk about how we got to where we are today and how we might get to where we need to go in the future. In a full disclosure, I list the organizations that I have the privilege of working on scientific advisory boards with. None of them are the subject material for this talk. None of them have devices for sale that I'm going to try to sell you. But it's important to understand that the lessons learned from these organizations, and many like them, are interwoven inextricably into the substance of the presentation. So let's take a step back. This is the most famous painting of a physician ever done, and it still speaks to us today. What do you see in this painting? Do you see the light of dusk and despair? Do you see the light of dawn and hope? Do you see the child's father hovering in the background? Regardless of what you see, I'll bet there isn't a person in the audience that doesn't see an attitude of care and concern on the part of the physician for the problems of this patient, in this case, this child. What was the state of medical surgical care when this painting was done? The Brits have a wonderful way with titles, right? The surgeon extraordinaire to Queen Victoria said, and I quote, "The abdomen, the chest, and the brain will forever be shut from the intrusion of the wise and humane surgeon." What a prediction. What an idiot. Okay? Be careful when you, the experts of today, make your similar predictions about the impossibilities of tomorrow. If the truth be told, the history of what we do and progress therein is always about innovation. It ain't about doing the same thing over and over again. Sometimes it's about doing the same thing, in this case, cautery, better, going from heated iron rods to temperature-controlled nanofilms. Okay. I give up. It's not advancing. It's great. That's good. It's great to talk about technology and have the technology fail, isn't it? So let's take a step back. I want to show you the Stanford operating rooms circa 1950. This is Frank Gerbaudy's open heart room. Dr. Gerbaudy preceded Norm Shumway as one of the preeminent cardiac surgeons at Stanford. Take a look at that operating room. See if you recognize anything that we use today. Slide, please. So what's different today? In our hospitals, the monitors are different, the pumps are different, the beds are different, our transport devices are different. Dialysis wasn't possible then. All of our circulatory assist devices are different. In the OR, the tables, the lights, the tools, the catheters, the sutures, the energy sources, scopes, staplers, ports, valves, and joints are all different. Gerbaudy didn't have ultrasound, CT, MR, PET, or functional imaging. His armamentarium was a few antibiotics, no antivirals, one antifungal, 2 chemotherapeutic agents, and open drop ether. We now have an incredible armamentarium. I'll try this thing one more time. Industry and our profession can be proud. And while the discussion about conflict of interest is an important one and outside the scope of this presentation, those that would eliminate the intersection between industry and the profession don't understand how these things happen. Let me say that again. Those that would prohibit the fair and well-understood interaction between the profession and industry have no earthly idea how innovation will be stifled if that is allowed to happen. Take a look around your operating room today. What do you see? First of all, better ways to see. Microscopes, video laparoscopy, better ways to work, perhaps surgical robots. Even our orthopods have tools that are somewhat updated, though they still look like they're shopping at Home Depot. That suggests an opportunity, and Home Depot isn't a bad place to start. Children's surgery in my own field has evolved over a decade, from big incisions to port-guided little incisions, now to almost exclusively port-driven thoracoscopic excisions of pulmonary lesions. What's now possible today? The fetus, the sub-1,000-gram baby, or the 350-pound child with an eating problem. The point is, there is no finish line, and anyone who thinks we're done is living in a dream. Even where we sit now matters, or doesn't matter. Think about our colleague and friend Jacques Maresco sitting in New York, taking out a gallbladder of a woman in Strasbourg. It's not often that the journal Nature publishes a surgical procedure. In fact, I couldn't find another example. But Jacques' demonstration about the unimportance of distance is a paradigm shift of gargantuan proportions. So if all this stuff has changed, how do we define what we do? And how do we define who we are? I had the great privilege to spend time with Mark Ravitch during my 2 years in Pittsburgh. Many of you know that Dr. Ravitch pioneered, along with Felix Steichen and Leon Hirsch, the entire field of staplers. Imagine your world without staplers. Ravitch wrote a typically Ravitch-esque treatise on staplers, and it's a wonderful book if you want to understand how we got here. Mark said, quote, "Surgery is not a place or procedure, but an intellectual discipline characterized by operative procedures, but defined by an attitude of an attitude of responsibility towards the care of the sick." Think about that for a minute. Think about that painting. I think he got it right. In 1983, we were walking back to his office, which was across the street from Children's, and we talked then a little further about, so what really is a surgical procedure or an operation? And we talked about how it was an act performed with instruments or by the hands of a surgeon, and I've updated that to think about it as an image and a manipulation. The manipulation used to manu for hand, used to be just our hand. Now it can be any energy source. And let's see if that stands up to assessment and scrutiny. So once upon a time, the image was a direct visual, and we worked on it with our hands alone. We learned that an operative microscope could provide us 40x magnification that allowed us to do things that were undoable if you couldn't see them. We learned that Cameron Najat's application of a video camera to an endoscope now made it possible for everybody in the room to see what's doing and to work with long-handed tools, to make those tools better and articulated and create 3D visualization with robots. We've learned that ultrasound, CT, and MR can be the image that we work on, and we may use cold or hot. We know that radio immunoguidance can be used, and I believe will increasingly allow us to see biologic activity a la PET scan. So for the first time, we're now operating on biologic images, and we may use photodynamic therapy. We may use shockwave energy, which we'll come back to, and who knows where notes will take us. It's now possible to preemptively operate on a gene. A child with MEN syndrome with the RET proto-oncogene will have their thyroid out before they develop thyroid cancer. You could argue gene-targeted surgery. What's next? Who knows? When I was a medical student, I heard this phrase, big hole, big surgeon. As my kids would say, not. And I think the fundamental mission of SAGES to do the same big essential operation with minimal access or with no access is an incredibly instructive and incredibly informed concept. Let me remind you of an incisionless operation, the lesson of extracorporeal shockwave lithotripsy. A stone is imaged, shock waves are sent to break up the stone, and guess what? Urologic surgeons perform this incisionless operation. They were smart enough not to define themselves as the incision for kidney stone doctor. They were smart enough to define themselves as said, we know the armamentarium of therapy for renal stones, whether it's cystoscopy, whether it's an open operation, or whether it's shockwave lithotripsy, and we should be the ones who understand stone disease to decide what's best for the patient. They've got the Swiss Army knives for stones. For those of you in the audience that don't see image-guided robotic radiosurgery coming down the pike, this is a freight train. Pay attention. We've always thought that targeted radiotherapy worked only in the brain, and indeed the gamma knife is restricted to having a bolted frame to your head. But it's now possible to deliver extracranial radiosurgery to spinal lesions, lung lesions, pancreas, liver, the kidney lesions seen here, prostate, breast, maybe even benign disease. From my own institution, Jeff Norton and George Yang, a phase 2 study showing efficacy in local control of pancreas cancer in widely metastatic disease. Local control is what a Whipple does. Think about the implication. If local control can be achieved with frameless stereotactic radiosurgery, what does that do for Whipple excisions? You heard it today, it will make them obsolete. Case of Sam So, one of our hepatic surgeons, hepatocellular cancer, 45 gray, 1 month, 6 months, gone. A lung cancer presented and reported by Richard White, one of our thoracic surgeons, here today, gone tomorrow. An incisionless ablation. MD Anderson has just announced a 2-year randomized controlled trial for resectable lung cancer. Not metastatic lung cancer, but resectable lung cancer. Jeff Norton in our own place is embarking on a 2 to 3 year randomized controlled trial of frameless stereotactic radiosurgery for pancreatic cancer. Trust me, our world will change. So advanced and emerging technologies will continue to shape our surgical practices, and there are a couple of ways that we can react to that. This is one. I don't recommend it. Think about how, over this last 50 years, innovations have shaped our surgical care, and then let's take a step forward about how do we anticipate and do something different. You can break the kinds of improvements that we've seen down into simple tool modification. Think about how Coker put a tooth on the tip of a clamp so he could grasp the goitrous thyroid gland. Think about the wound vac, basic, simple machine, now considerably improving the care of complex surgical wounds. There are some tools that are revolutionizing the Fogarty catheter, the Greenfield filter. Great story of how Laser Greenfield was talking to a oil pipeline engineer at a cocktail party, and it turned out they had a shared need. The oil pipeline engineer's need was to sieve clots out of oil pipelines. Laser's interest was in sieving thromboembolic clots out of the vena cava. The application of the entire tool set that we've seen, in particular with the video camera, revolutionized and was perhaps the sole purpose, the sole reason that SAGES came to be. Think about how these revolutionizing technologies enabled what we did. Cardiopulmonary bypass allowed open heart surgery in the still heart. Pulse oximetry, the young people in this audience take pulse oximetry for granted. It wasn't always there. Lasers, frameless stereotactic radiosurgery, gene chip microarrays, all have improved what we do for patients. If the truth be told, the development of all of these things was left to a few rare gifted individuals or to chance. And when was the last time that we as surgeons liked to leave things to chance? We talk a lot about translational medicine, and at Stanford, the catchphrase is bench to bedside. I would argue that there is a wheel of understanding the clinical problem and improving it, not only from bench to bedside, but for those of us real doctors that understand the real patient problems, who can then take the problem, figure out how to solve it. That's translational medicine. There's only one problem with translational medicine, and this cartoon is illustrative. We understand the basic science. In general, that works out pretty well. And we understand the commercial process. But this little detail in here, then a miracle occurs, needs to, as it's implied here, I think we should be more explicit in step 2. And so the fundamental process and the fundamental guiding principle for the Biodesign Innovation Program that we'll talk about next is to try to be more explicit about this miracle. Here's the problem. We all have more and more focused our practices, and I'll bet there isn't a surgeon in the audience that doesn't occasionally feel like they're on a treadmill. The additional truth is that technology is becoming increasingly complex, so the days of Tom Fogarty fly tying a finger cot on a catheter in his garage are a little trickier when we think about minimal access surgery, MEMS, and nano. And surgeons' understanding is diminishing. One of my senior surgeons, when they were asked how RF energy worked, said, "It's magic." Actually, it's not. But I would suggest to you that that creates a crisis in the pipeline of surgeon innovators, and that's not good. So if once upon a time the specialty and the technology overlapped, the aha moment could happen and has happened. But as time has gone on, technology more difficult, specialty needs, RVU production have really separated the two, and that gap prevents innovation. So we've designed a concept and a program to try to bridge that gap to preserve the aha moment. So 8 years ago, we asked the question, why leave innovation to chance? Again, leaving things to chance is not a surgical principle. Could we study it, understand it, and teach it? And I was 2 years into my move to Stanford, and it was clear that that was a unique opportunity. The environment was rich in intellectual capital, rich in financial capital, and perhaps most importantly, rich in risk capital. the willingness to take a chance, to pursue a grand idea, and to solve problems that hadn't been solved before, and the fact that the environment is incredibly full of medical technology companies in the Bay Area says something. This is a partial list of medical device companies that are based on Stanford student and faculty technology, a partial list. More importantly, this is a partial list of real-world mentors who interact with the program, who come from all walks of life, be it from finance, from business, from intellectual property. Karen Talmadge, the CEO at InnoSpine. These are real-world mentors who can not only talk the talk, but walk the walk and add a tremendous sense of reality to our program. So we call it a work of art in progress or surgery outside the box. So 8 years ago, we said, instead of leaving this to chance, here's what we believe. The process of innovation can be taught, and our goal was to create a next generation of medical device innovators. Russell Wu, a now budding pediatric surgeon, pay attention to him and the other grads of the program. So the vision was to develop leaders in biomedical technology innovation, collaboration, innovation, and education. Okay, I give up. Can you advance the slide, please? Mission statement: to train a next generation of innovators, to facilitate translation of new and emerging technologies to patient care, and to drive patient-focused innovation. So these are not science fair projects. These are designed with real clinical problems. Fogarty is the godfather. Most of you know his name. All of you know his catheter. You may not appreciate the breadth and depth of his contributions: greater than 100 surgical instrument patents, more than 30 successful startups, the Jacobson Award winner, the Lemelson MIT Award winner, the first and only surgeon to so be honored, and an inductee into the National Inventors Hall of Fame. Tom will tell you that translational medicine is not a science fair project. It is a product in a box with a 1-800 number for sales and service, and it's what gets the surgical patient better. Most importantly, it leverages your work and your treatment to millions of patients. Rodney Perkins, another incredible physician, surgeon, innovator, entrepreneur, put it this way in his Fogarty lecture 6 years ago. We as surgeons are peace workers, one at a time, one patient, one operation, and we produce considerable healthcare effect. What if you're a Judah Folkman, a Norman Shumway, a Laser Greenfield, or a Tom Fogarty? Your discoveries, your inventions, your innovations treat millions of patients locally, regionally, nationally, and internationally. That is a heck of a way to expend your time and energy and to leverage what you know to develop new solutions. So the concept was invention, discovery, tech transfer, ethics and policy, and education across that continuum. The leadership group: Paul Yock, an incredibly inventive cardiologist. The Smart Needle is a Yock design. The entire field of intravascular ultrasound is a Yock design. Faculty from the School of Engineering, School of Medicine, and School of Business. A entire person devoted to ethics and policy. 2 guys that run the fellowship, my friend and colleague Todd Brinton, and most importantly, from my point of view, Mike Gertner, a general surgeon trained at UCSF, perhaps the most inventive and creative young surgeon that I've ever met. When we bring these teams together, we inevitably find conflict, and so we have a part-time psychologist, and he is a real licensed psychologist as the team shrink. Just as SAGES has an international mission, we believe that that's part of our responsibility, and so the Stanford India biodesign piece we'll comment on. And last but by no means least is Craig Milroy, who runs our prototyping facility. He's the MacGyver in the group, so if you give him a Weber grill and a roll of duct tape, he'll make a lunar module. I would emphasize what we do and what we don't do. Not all tech transfer is the same. Pharma is not what we do. MedTech is what we do, and it brings together mechanical engineers, electrical engineers, physicians and surgeons from all aspects of adult and pediatric medicine. And the innovation process, as you'll hear, is and most importantly needs-driven rather than discovery-driven. We're fortunate to have a facility that sits immediately between the School of Engineering and the School of Medicine in the Clark Center, 4,000 square feet of teaching facility. But it's not the facility, it's the educational program and the students who come to us. This is one of our early teams, and again, we take advantage of Bay Area confluence of capitals. When we put people together who think differently, good things happen. So we have a surgeon who thinks like a surgeon, a biologist who thinks like a biologist, an ME guy, and a computer science and a double E guy put together. Once the sparks settle down, good things happen. We bring them together in a 1 or 2 year fellowship, and this is what it looks like longitudinally. A summer of boot camp, and we'll talk about that. A period of time to understand a clinical problem, an introduction to the design school and its private component, IDEO. IDEO is a design studio that developed the Palm Pilot, the original computer mouse, and there's heavy IDEO influence in all of the Apple products. A period of time to try to understand what's the real market and what's the intellectual property around the needs that they've identified, a project course, a business plan. You got to write it up, and at the end of the day, you have to raise money. The second year for the surgeons who elect to spend a second year is very much like a postdoc in our other surgical labs. The fellow chooses an independent project based on their first year experience and their future interests. They may do a startup, they may be an intern at a venture firm, they may work at the FDA, or they may work at a large company, and they have an option to get a master's in bioengineering. Here's what it looks like over time, beginning with boot camp, and boot camp is aptly named, 40 to 60 hours a week for the summer. We try to get the clinicians, the engineers, and the business people to talk to one another, to learn their language, and to teach each other. We teach them intellectual property, the entire regulatory process, and financial essentials. We bring a team together and do a number of team-building exercises that aren't just about throwing tennis balls at each other. We teach them how each other thinks. We teach them design thinking, ethics, and law, and we provide them with a starter project. Once that's done, the clinical immersion starts in earnest. The teams put on scrub suits and live for 2 to 3 months in the hospital. They crawl around everything from the back of ambulances to the operating room, the cath labs. We've done projects paired with clinical disciplines ranging from anesthesia to cardiology to GI to neuro, both surgery and neurology, orthopedics, and virtually all of the surgical specialties. The upcoming year is going to be focused on advanced GI, and Jay Pashrika, who's our new chief of GI gastroenterology at Stanford, and I have big hopes to help develop some devices for next generation surgical care. When they crawl around the hospital, we ask them to look, but of course they're not practicing. So they're privileged to be a fly on the wall and to watch what we do. They may spend time in the sleep lab. They look at an operation from a scrub nurse's point of view. They look at the flow from a circulating nurse's point of view. They look at the operation from the head of the table, from the anesthesiologist's point of view. They listen to what people say, they watch what they do, and they watch what they don't say and what they don't do. Henry Ford once said, if I'd listened to the customers, I'd have given them a faster horse. There's a lot of insight there into what's the real need, rather than, it'd be nice to have a foam cushion on the handles of this mosquito clamp. Again, the privilege is that they're out of the clinical combatant role and allowed to think differently about what's going on. When they crawl around the hospital, they find needs. In fact, this list of 380 clinical problems was identified in less than 2 months. It ranged from simple things like trying to keep a deep brainstem stimulating electrode in place to how we measure sponge blood loss. Once they've got a big list of needs, you got to decide, all right, is it a problem? What does it mean? Get the facts and get the numbers. Like it or not, the reality is big markets, big problems are where people are likely to invest their time, their energy, and eventually their capital. They go through then a very careful process of trying to solve a problem, in this case OSA, or obstructive sleep apnea, class of ENT. This is need number 323. They try to assess how big is the market, What are the impacts to the patient, impacts to the healthcare provider, and try to put a general notion on, is this in their top 100 ideas? Is this in their top 50? Is this in their top 22? And how much more do they want to think about it? They choose the top needs, and I can assure you become incredible experts. These young men and women learn more about the anatomy, physiology, pathophysiology, market dynamics, competitors, and current solutions than you can possibly imagine. Working 60 to 80 hours a week for the surgeons, it's a little bit of a break, and it puts everyone in real startup mode. They understand the potential markets, and most importantly, the gotta-haves and the wanna-haves. And they produce a guidance document for innovation on every problem that they decide to solve. So boot camp, a whole bunch of needs that are then focused down to several needs, and then a new process from opening the door to closing the door to opening the door. Brainstorming isn't just BSing. Whiteboard-lined room, and actually some rules. And this is Mike Gertner in action. Mike brings a real fun characteristic to the whole thing, one of our current senior fellows, Vanita. Defer judgment. Don't immediately say, we tried that 20 years ago. Encourage wild ideas, and most importantly, build on those wild ideas. Stay focused on the problem at hand. Surgeons and engineers are visual, so we do a lot of drawing pictures. There's a lot of stuff and junk around that allows us to get concrete about what these things look like, and again, have fun. You now have to narrow the good ideas down to, does it meet the requirement? So in other words, it may be a great idea, but if it violates the laws of physics, it's not likely to be manufacturable. Is it feasible technically and scientifically? What's the clinical risk? What's the intellectual property position? Is the team interested? So the notion that a single problem has one idea is crazy. A mind map is constructed. You see how big this is. This is wallpaper size sitting on the wall, and I'll show you a little corner of it. So for obstructive sleep apnea, an option is to bypass the occlusion in the back of the airway. Could be a nasal trumpet. That got a green flag. Could be a self-inflating balloon. The team decided that cutting out the back of the tongue, while it might solve the problem, probably is a red flag relative to would that be workable. The concepts are then selected, not only on the complicated calculus that they put together, but most importantly is what's the risk-reward component. A high reward, low risk, good quadrant to be in. A low reward, high risk, even I understand that's not a place you want to spend a lot of time. There's then an iterative process that goes on around the final concepts that are selected, the needs, is it really a need, and it becomes ultimately what we call the need statement. In many ways, it is the genetic code of the solution. Once upon a time, the heart surgeons might have thought it's, quote, a better method to do a coronary artery bypass graft. That is flat out wrong. The real problem is a better method to revascularize the heart. And in this single notion, you get a much clearer understanding of what the statement is. It's not about what you do, but what the patient needs. And if our heart surgeons had thought about this 30 years ago, they might be in quite different situation than they are today. So, lots of needs, narrowed down, brainstorming to concepts, small number of concepts going forward, open the door, close the door, open the door to concepts, narrow it down, and then you got to get real. So prototyping happens early. It hope happens cheap. This is a great illustrative example. The idea of a Swiss Army knife or a multifunctional laparoscopic tool seemed like a good idea. We put a stopwatch on Craig Albanese, my partner, who's incredibly slick, and he did not believe that 30% of his time was spent in changing laparoscopic tools. So we said, what if you took one of those pens that has 4 different colored inks, and you could sequentially insert and deploy a cutter, a grasper, a hook, and perhaps a needle driver. Well, prototyping immediately showed us why that was wrong. The geometry and the size made this thinkable to be something like a 2.5 centimeter tool. we're out of laparoscopic tool range. So we immediately threw that idea away. We teach surgeons how to weld, we teach chemical engineers how to dissect the liver, and we teach business people a sense of fun. Once the early prototyping and the cheap prototyping gets done, we take it to the co-laboratory, which has got some simple tools, devices, great for making catheters or laparoscopic tools that are simple. And ultimately, we take it to the product realization lab, which Craig Milroy runs, and it is possible to prototype anything here. At the end of year 1 and year 2, especially for our surgeons, it becomes a time of research and development and intellectual property, business and project planning, and most importantly, getting funding. The NIH is probably a fool's errand, but the National Collegiate Innovators and Inventors Alliance has been incredibly generous to us, and I'm eternally grateful to them. SBIR is a real option. Our Office of Technology Licensing offers really tiny little, quote, birdseed grants, but it's amazing what you can do with $10,000. And at the end of the day, if you don't understand regulatory and reimbursement, you're going nowhere fast. What else do we teach? The challenge is that technologies develop faster than our ability to prove whether they really work or not before you got to have it. And that remains to be seen, whether we can develop notes in a way that actually is good for patients. At the end of the day, ethical and evidence-based innovation is what we're all about. We teach an undergraduate class that is cross-listed between the School of Engineering, the School of Medicine, and the Graduate School of Business, and my friend and colleague Stefano Zignos, who's a professor in the business school, is invaluable. So we get 60 young students to spend 2 quarters with us. At the end of the year, a project competition, and it's amazing what a few $1,000 as a prize will do to creative thinking amongst undergrad and grad students. We offer a graduate certificate in biodesign to people who work outside the university. We do a med-tech career fair, and we bring business and our grads together. That's a supply and demand advantage. We offer an Fda Fellowship, as I alluded to earlier, where a fellow can spend 6 months to a year at the CDRH learning tech assessment or in research, and it's pretty clear that the FDA is in desperate need of bright surgeons who understand clinical problems. We educate leaders outside the university. We run Emerging Entrepreneurs, which is a 2-day intensive 12 to 18-hour days on a Friday and Saturday for emerging entrepreneurs, not only in the Valley, from beyond. We sponsor a number of speakers that range from Dean Kamen, the inventor of the Segway, to Fred Moll, whom many of you know from Origin, from Intuitive, and now Hansen Medical. Perhaps one of the most enjoyable events is the annual Fogarty Lectureship. We prevailed upon Fogarty to give the first one. Who here knows Bill New? You use his device every day in your operating room. Bill was a doctor, anesthesiologist, electrical engineer who invented the pulse oximeter. Andy Grove, I'll bet most people know Andy Grove, CEO of Intel. And this coming year, Jacques Moresco, our colleague and friend from Strasbourg. We're trying to codify this knowledge and information in a textbook. I expect that it will be available probably in the fall. It is by no means a cookbook, but it does codify the general processes and principles. And so what happens? What's the output of this stuff? In 2001, our fellows have been working, and you notice the clock on the wall says 4:35. I can assure you that's not 4:35 in the afternoon. A novel catheter to be steered into the coronary sinus for biventricular pacing. Our fellow in 02, working with Todd Alleman in orthopedics, a novel way to insert a balloon catheter into the compressed vertebral body of a vertebral compression fracture and the installation of bone cement to jack it up, initially as Innospine, acquired by Kyphon. Here's a good one, Amir Belson, a pediatrician who worked with us, who developed a segmented smart colonoscope that knew where the previous position was so that it could move like a snake rather than like a garden hose. Amir was smart enough to recognize that colonoscopy is one thing, but notes is another thing. And so this sort of smart tool, segmented and knowing, is potentially an enabling device for notes. Kerberos, a really important notion about carotid stenting and angioplasty, are the plaque and emboli that result. This is a sieve on the lead end of the catheter to protect the patient's brain. Our MacGyver here, Craig had an incredible impact on the design of that. And in aggregate, there are now 10 startups in varying phases, varying status, and most importantly, more than 4,000 patients' lives have been affected well because of these devices. And if you look at the timeline, the reality is this is only going to increase over time. These are the surgical fellows, these incredibly bright young men and women that I've been privileged to work with. They come from varying walks of life, from UCLA, from Brigham and Women's, from Penn, from Pitt, a urologist here, a neurosurgeon. Our current senior fellows, James Wall and Vanita, they're both here. Feel free to buttonhole them and ask them what their experience is like. We've talked a lot about products, devices, but if the truth be told, our real product are the grads of the program. This is not just the surgeons, but the engineers and the business crew that come to our graduation every year, that network with one another, that will alternate and partner with people on projects for the next 20 and 30 years. This, in our mind, is what we're really all about. We had 2 fellows from Mexico, which opened our eyes to the big world, and in alignment with the global mandate that John Hennessy, our president, has suggested, we said we need to expand this program not just to Mexico, but to their Stanford India Biodesign program. And so we have 4 incredibly hardworking, bright colleagues from India who spend 2 years with us, alternating between Stanford and Delhi to become the next generation of teachers and trainers in India. People ask how we fund this. This is a startup, and so not only chief cook and bottle washer, but fundraiser. We've submitted for training grants. They've been triaged out. That's probably not a well that you want to go to. As I indicated, the NCIIA has been incredibly generous to us. SBIR is a great opportunity, and the R21 mechanism might be worth thinking. But at the end of the day, we're incredibly dependent upon philanthropy. If you look at our annual budget, more than 3/4 is based on philanthropy. It's our sincere thanks to these, our corporate sponsors, Edwards, Abbott, Medtronic, Boston Scientific, J&J, and Stryker, and our venture partners. So what's come of the whole thing over the course now of 8 years? 39 grads, 3 senior fellows, 8 rookies, 50 invention disclosures, multiple abstracts, posters, chapters, manuscripts published or presented, real-world funding successes from angels all the way out to the venture, 10 startups and 1 more in the pipeline. In summary, what I've tried to lay out for you in this component is a 2-year experiential course that teaches a process of wayfinding. The notion from the ancient Asian proverb, give a person a fish, feed for a day, teach a person to fish, feed for a lifetime. What we've learned is to learn how to fish, you have to go fishing. It's instructive when you catch fish, and fish fries are fun. So by way of summary in this presentation, and very much inspired by the example of Karl Storz, I've tried to suggest several things to you. One, that surgery and surgical care have evolved over the past decade and will continue to do so. We as surgeons need to be very thoughtful about how we define ourselves, and I would argue that Mark Ravitch's concept provides a really useful framework for clarity around an image and a manipulation. Surgeons ignore technological advancements at their own peril, and over the last 10 years, it's been my privilege at this incredible institution, Stanford, to tell you about an early experience with an innovation training program, suggesting strategies for all of us for the generation of, or for a next generation of Tom Fogartys. I'll leave you with this thought. The art of surgery is not yet perfect, and advancements now unimaginable are still to come. May you and we all have the wisdom to live with this with grace and humility. It's as true and applicable today as it was when Halsted said it 100 years ago. Thank you again for the privilege of speaking with you.
It's a fantastic job, and Dr. Krummel has been incredibly generous with me personally with his advice, his counsel, and beginning our own biodesign and innovation program, and he shared with us many things to help us get off to a successful start. It's a great honor to have him here with us. I'm presenting to him a plaque that says, successful innovators recognize that discovery of great ideas come from looking at the same thing as everyone else and observing something different. Presented to Thomas M. Krummel, MD, the Storz 2008 Innovative Technology Lecture.
Great job. Thank you.